Good morning, dear colleagues, ladies and gentlemen. Welcome all of you to the last session of this symposium, which is organized by Drs. Özsan and Dispenzieri. Symposium was wonderful and has high quality, high scientific quality. Now we are going to chair this session with Dr. Sayram. We have 4 cases. I will handle the first 2 cases. Dr. Sevindik will be presented his cases. Please, Sevindik.
Thank you. How we use this device? These are electronic voting devices. Okay. First, we have to push the CA button, the red button, to open the device. We have to activate first the device. And then, if you have a question on the screen, first you select your choice, A, B, C, D, or E. Not now. And then press OK at last to send your question, your answer to the system. Okay? Yes. If you want to change your selection during voting time, please press another key and then send after the OK button. That's all. Thanks. And at the end, please leave the keypads on the desk. Yeah. Thanks.
It's very complicated, I think it looks.
Good morning. First of all, I want to thank you for coming and joining this beautiful meeting. And I want to appreciate for those wonderful and comprehensive presentations. In the context of those presentations, we will discuss some cases. This is the first case. If I should manage to go on. Yeah. This is a 57-year-old male patient. First was seen by a dermatologist because of the vasculitic purpuric lesions on the lower extremities. Skin biopsy applied and revealed leukocytoclastic vasculitis. Remission achieved with short-term corticosteroids. While searching for the etiology of the vasculitis, the only pathological issue was the urine sample showing microscopic hematuria and mild proteinuria. Post-medical history revealed no chronic illnesses or medication. Physical examination revealed diffuse purpuric lesions on distal lower extremities. And he was referred to nephrology department because of the mild proteinuria and microscopic hematuria. The nephrologists applied kidney biopsy to identify the cause of hematuria and proteinuria. The kidney biopsy revealed membranous linear IgG, IgA, and kappa chain deposition with mesangial matrix expansion. No tubular casts was seen. Congruent was negative. Electron microscopy revealed mild basement membrane thickening, but electron dense deposits weren't identified. Non-specific DIF findings, further evaluation for light chain disease and anti-GBM nephropathy was suggested. There were no clinical and laboratory signs of anti-GBM nephropathy, hence the patient was referred to our department in order to be evaluated for a possible or probable plasma cell disorder. Regarding the hematological evaluation, no signs and symptoms attributable to a possible hematological malignancy. He had used corticosteroids for 3 weeks at a dose of 0.5 mg/kg over day and was steroid naive when admitted. No other medications. Physical examination revealed no other pathology than the faded purpuric lesions. Laboratory imaging tests were ordered. At lab studies, there was no anemia. Renal functions were okay. No renal failure. No hypercalcemia. Albumin was 3.7. Globulin was 3.5. Beta-EQ microglobulin was 2.5. IgA was 1263, IgG was 553, IgM was 35, kappa light chain was 535, and lambda light chain was 63. The urine sample showed 10 RBCs over a higher pivot field and 0.5 grams over liter proteinuria. The electrophoresis and immunofixation revealed a IgA kappa monoclonal gammopathy. The urine immunofixation could not be evaluated because of low protein content. The bone marrow aspiration revealed 40% plasma cells with some bizarre shapes beyond multinucleated plasma cells, and the biopsy revealed monoclonal plasma cell infiltration stain predominantly with kappa. IgA monoclonal gammopathy and 40% plasma cells on bone marrow examination, so he was diagnosed with IgA kappa multiple myeloma, ISS stage 1. He had no anemia, he had no renal failure, no hypercalcemia, so there were no CRA, but B was a question mark. And also a question quotation to R, because he had microscopic hematuria and mild proteinuria, and membranous linear IgG A and kappa chain deposition with mild mesangial expansion. And he had no adverse cytogenetic risk factors. Regarding bone disease, the skeletal survey was all normal, so there were no bone disease. At this time point, multiple myeloma with no CRAB, but pathological renal features, do you recommend systemic therapy? Yeah, that was negative. Urine, it was 450 grams over day. Yeah, milligrams over day. Yeah, you can vote now. Agrees.
Yes, A or B. Let's vote. Do you have any comment or question?
Yeah. 72% wants any further tests. Which tests do you recommend? We can get your comments.
If you have question or comments.
Yeah, the free light chain ratio was abnormal, depicting kappa. The quantity, I don't know, I do not remember now, but was over 1.6. Abnormal, yeah.
Please, Dr. Gers.
Dr. Kyle taught me that if I wasn't sure, I should wait. And so if you're not certain that therapy is required, half gram of protein, minimally active sediment, not hypertensive, creatinine normal, no other features of active disease, I voted not to treat, and I'm not convinced that any additional diagnostic testing in a patient who's free of pain is going to help me solve it. I think this patient is just going to need quarterly follow-up to determine whether this problem's been present for a short time, a long time, and I'm having trouble reconciling the leukocytoclastic vasculitis with purpura and how it exactly is relating to the presence of the smoldering myeloma. But I wouldn't feel compelled to treat because of the purpura either.
Yeah.
In terms of bone diseases, do you think the normal X-ray is enough?
That was the point we will furtherly discuss.
One more question maybe from me. Did you perform any skin biopsy for this patient?
Skin biopsy revealed just leukocytoclastic vasculitis. No amyloidosis.
One time or repeated?
Just one time at another department, at another hospital.
No plasma infiltration?
No plasma cell infiltration.
No infection signs?
Yeah, no infection signs, no deposition, no amyloidosis. And this is the case going on. Because of slight and very mild low back pain localized to lumbosacral region and an intention to tract of us, we applied PET-CT and we saw lots of lesions attributable to multiple myeloma. Here you see a costa, sternum, sternal region, the lumbar vertebral corpus, another lesion, the iliac bone, and acetabular region. At the PET-CT, we have seen multiple lesions with SUV of 3.5 to 6.4 compatible with multiple myeloma bone disease. So there was a B positive for this patient. And now, do you recommend systemic therapy?
Let's vote. A or B?
I would like to make one point clarified. And do you think that these bone lesions, since they were there, needs to be treated or not? Because there is no plasmacytoma as far as I can see from PET-CT.
Yeah. I think we agree, 96% recommend systemic therapy.
Our population likes to treat.
Yeah, as us.
Any comment? Especially from our faculty? Did you still wait and see, Dr. Gertz?
I have to admit, I don't believe that this patient's back pain are based on those PET scan findings. And so, well, look, I mean, I can't speak for Turkey, but in the United States, 60% of people have mild low back pain. And so we see these little tiny features on the PET that don't involve cortical bone, and yes, they indicate activity, and I realize that the patient ultimately is going to require treatment. But I must admit, I'm a little bit torn, and I'll be very honest, oftentimes in my practice, I don't order the PET scan because sometimes I don't want to get the answer exactly that's going to force me into an awkward position, because now the patient is looking at the PET scan results, and I'm thinking maybe I could probably still observe, and they think I'm not sane. The patient has very, very low-grade disease, and again, I don't think there's any. The big deal would be threat of fracture to me, and none of those lesions look to me like there's any imminent fracture coming. I don't know.
Anyone?
I have to disagree. I would treat this patient. The main reason being, I think the two potential catastrophic things just kind of waiting around the corner, especially the kidneys. We already know pathologically there are lesions there. He has light chains, and the last thing I want in today's era is somebody actually showing up with renal failure, because once that happens, you never get back to where you were in the beginning. So if it was just one or the either of those, I would have waited. But with both the things happening, I would probably err towards treating.
I'm going to just throw one thing. I agree with Shaji. I'd lean towards treatment in this patient. But the one thing that's very unsatisfying about this case is that it's hard for me to say how the mechanism that we have the purpura, and also the idea of red cell cast is not a very common presentation for myeloma cast nephropathy, nor, I mean, you know, it looked like cryo from the very beginning, and you'd say this is some kind of, you know, you have a leukocytoclastic vasculitis, you have, again, the little bit of red cell, the active sediment. It's really along those lines, not a typical myeloma presentation, so it's a funny case.
Yeah.
Okay, can we say the paraneoplastic syndrome in multiple myeloma?
There's some cases in literature presenting with just leukocytoclastic vasculitis. Mild cases.
As Dr. Kumar mentioned, something could happen, but I think it would be extremely unlikely for it to happen soon. And I'm in Dr. Gertz's camp. I would bring the patient back in 3 months, look at the proteinuria, take a look at the bones again, and get an idea of how long this is been going on. Again, going back to the duration of MGUS in the serum of a patient with an average of 15 years, I think the nidus of all of these abnormalities begins a lot further back than what we have thought of before. So I think we have a little time, and I'd feel a little more secure by just waiting a little bit and letting it declare itself.
Thank you.
Okay. One more.
And what we did, we started therapy.
Do you have any comment about this case?
The treatment was, because he was eligible for autologous stem cell transplantation, it was VAD. Because of the governmental issues, we have to start with VAD, and he's now getting VADs.
Let me ask the last question to audience. What is the prognosis of this kind of patients who had a paraneoplastic syndrome at the beginning in multiple myeloma? I know it's a rare case.
There's certainly a disconnect with neuroplasm, something that data globulin. I'm already worried about sampling issues. And Dr. Learn isn't here, but again, it's a question really of, it's a half gram of proteinuria with a normal creatinine, and the typical patients that he's asked us to treat with gammopathy of renal significance, oftentimes they're in the nephrotic range, or they're hypertensive from the activity, or there's actually a decline in creatinine clearance. So there's actually an end point. The end point here is what? No red cells in the urine, big deal. Or the urine protein goes from a half gram to a tenth of a gram. And I'd venture to guess, probably preempting Dr. Kyle, that since you started the VAD, this patient feels worse than when he came in the first place.
Thank you. Time is short. Let's start the second case.
This is another patient who was 51 years old at the diagnosis and male, admitted to an orthopedist with the complaints of neck and back pain present for 2 months. The intensity of the pain increased gradually. He had difficulties on walking. Past medical history revealed no chronic illnesses or medication. Physical examination revealed spinal cord compression signs that approximated to lower cervical and thoracic region. MRI ordered to clarify the etiology of pain and difficulty on walking. The MRI at diagnosis revealed multiple lesions, which is compatible with multiple myeloma on vertebral column, most prominent at C6 thoracals and L4. Compression fracture was present at C6 and a soft tissue mass arising from C6 and extending to bilateral paravertebral area and spinal cord. Spinal cord compression at this level was seen. Soft tissue mass at right costovertebral articulate at T7 and soft tissue mass at L4 obliterating right lateral recess and neural foramen. This is the MRI. This is showing the cervical spinal cord compression. Lab studies revealed at presentation no anemia, no renal failure, no hypercalcemia. His albumin level was 4.8 and beta-IQ microglobulin was 2.4. IgA was 47, IgG was 803, IgM was 29, FLC ratio was 1.4, urine protein was negative. Electrophoresis and immunofixation revealed no monoclonal gammopathy. Skeletal surveys revealed lytic lesions at cranium and femoral bones. Bone marrow aspiration and biopsy revealed 35% plasma cells and plasma cell infiltration at biopsy. Multiple plasmacytomas and bone disease and 35% of plasma cells on bone marrow examination. Multiple myeloma non-secretory with multiple plasmacytomas and bone disease. ISS stage 1 was diagnosed. He had no anemia, no renal failure, no hypercalcemia, but bone disease. At multiple myeloma with bone disease and spinal cord compression, what is your choice of therapy? Systemic treatment, and radiotherapy. Systemic treatment, radiotherapy, and surgery. Yeah, of course, difficulty on walking and neurological signs.
And without the urine assessment, it's only the serum.
No, the urine assessment was negative. Yeah.
We would check urine, but with the cap-off ratio of 1.1, The likelihood is small. This is likely a very legitimate non-cingulatory patient.
Because
Should-
of the suppression in the electrophoresis, the annual mold immunoglobulins are suppressed, but except for one, so two are more suppressed.
It's very hard regarding our laboratories.
Before diagnosing of the non-secretory myeloma, should we check the IgD or E levels without any monoclonal gammopathy? On
light chain?
Hmm.
Normally, you have to have a light chain.
And then we reflex it to D and E, but with no kappa or lambda. I don't know if it's,
I think we have to realize here that we have a patient with a paravertebral plasmacytoma that's compressing the cord, and that is damaging the cord immediately. And I think we have to get that patient on dexamethasone and to the radiation therapist right away and take care of that lesion at C6, and then proceed at a little more leisurely pace with our systemic therapy, and not worry anything more right now about any additional diagnostic tests.
And
let's vote.
what we did, we started on cyclophosphamate and dexamethasone, and then radiotherapy applied to cervical region. After second cycle of cyclophosphamate and dexamethasone, there was stable disease. Bortezomib and dexamethasone initiated after 3 cycles of VD, a partial remission achieved. And following bortezomib and dexamethasone, patient was operated by neurosurgeons and instrumented, fixation and cement to C5 to 7. After a successful operation, symptoms related to spinal cord compression were totally regressed. After surgery, patient directed to stem cell transplantation, 2.5 million cells transplanted after MEL 200. Successful hematopoietic engraftment was achieved and patient was discharged on day 25. At 100th day evaluation, 3% plasma cells on bone marrow examination, little regression regarding bone disease, and no new plasmacytomas or lytic lesions. Do you recommend maintenance therapy at this time point? It was again same partial response.
How could you monitor the therapy response under the maintenance? If you do, I think it's a very hard question. I mean, you don't have any light chains in the plasma, no paraproteinemia, so it's not easy to monitor this patient under the therapy of maintenance.
The 70%.
Do you have any
commented
comment?
Yes.
Do you have any comment on these results?
I think it's a pretty happy ending. I think it's a very good outcome. Yeah, I think that the patient was treated state-of-the-art, and I think this is an excellent result.
But the show is just beginning.
Just beginning.
Patient was followed with only biphosphonate therapy until the 11th month of autologous stem cell transplantation. At 11th month, he admitted with swelling on right temporomandibular region and visual disturbances, blurred vision and diplopia. MRI was ordered, and it revealed a newly developed plasmacytoma at right inferotemporal region, a hypointense soft tissue lesion at left with infiltrates petrous apex and carotid canal, infiltration of 6th cranial nerve around duralar canal, and pachypile infiltrations. This is the MRI showing the plasmacytoma. And this is the lumbar puncture CSF of the patient full of plasma cells. At this time point, multiple myeloma with CNS involvement, what is your choice of therapy? Systemic, radiotherapy, intrathecal, or the combinations of them?
Yeah, please, Önder.
Yeah, at this point he had no 17p deletion or 13q deletion and I think 10 metaphases with no clonal abnormality. Yeah. HIV.
I mean, I don't usually test for HIV in myeloma patients, but when they have very aggressive and unusual disease, I tend to just see if they're immunosuppressed.
Yeah, that's a good point, but I do not remember now that I think yeah. Routine, just as routine, we checked. Oh, the audience set systemic radiotherapy and intrathecal therapy. What we did, we immediately started cyclophosphamide, doxorubicin, dexamethasone, and bortezomib treatment. Concomitantly, intrathecal methotrexate applied. After second cycle of chemotherapy, patient experienced epileptic seizure, plasma cells decreased but still present as CSF. Cranial radiotherapy applied. After 3 cycles of chemotherapy, 6 cycles of intrathecal therapy, LP negativity achieved, and temporal mass significantly mass mildly regressed for short term. This is the MRI after 3 cycles of cyclophosphamide, bortezomib, doxorubicin, and dexamethasone. You see a response, and the pile infiltration seems to be regressed. And this is a PET-CT at that time point. There was still activity at the plasmacytoma.
I have a comment.
Do you recommend stem cell transplantation at this time point? Yes, re-autologous. Yes, allo, with RIC or myeloablative conditioning, or no?
What about the plasma cell count in peripheral blood at this time?
There were no plasma cells at peripheral count. There were no plasma cells.
No plasma cells in the peripheral blood.
Yeah.
Since the steroids has very dramatic anti-myeloma effect, do you think that it's better to perform intrathecal therapy for this patient with prednisolone or dexamethasone instead of methotrexate?
There are some reports regarding this. Yeah. Yeah. Okay. The audience said, yes, we can re-autolog 35%. Yes, allo stem cell transplantation 50%. But the truth was, because of social issues, patient requested oral therapy and he was tired of therapy, and Lendexa started. Patient did well until the 5th cycle of Lendexa. At the 11th day of 5th Lendexa, he was hospitalized with pneumonia and sepsis despite antibiotic prophylaxis. Despite a clear cranial MRI, he was lost due to severe sepsis.
So, I mean, myeloma meningitis, I mean, the 1-year survival is like 15%, and the largest case series is like 20. And so, the decision not to proceed with aggressive therapy was sound based on what is expectation, and the consideration of an allogeneic transplant would not be based on data, but just because there's, quote, nothing else to do, but no reason to believe it would be effective. And I don't think the clinical course was in any way unexpected.
Yeah.
It was just a very bad biologic. Myeloma meningitis within 24 months of diagnosis. It's there.
Unfortunately,
I
this is
have
a
a-
summary of the patient.
I have a comment as well.
Yeah.
Transplanting these patients, either auto or allo, I would choose a drug that penetrates the CSF. So, like something with Thiotepa, and maybe combining one of the new agents like bortezomib in the conditioning regimen. Just designing a conditioning regimen, as we have nothing else to do.
Yeah, that's a good point.
Thank you. Do you have any comment or question on this case?
He was survived 9 months more after CNS involvement.
Okay.
Let's
And
move to next case.
another
Your
case.
turn.
This is the case 3. Considering solitary osseous extraosseous plasmacytoma, what is your treatment choice? Radiotherapy, surgical excision, systemic chemo, and radiotherapy.
Please vote now.
You're just beginning with,
Without any comment on question.
yeah. With no comment. Okay. %65% with radiotherapy, 15% with surgical excision, and 18% with systemic chemo and radiotherapy. This is a 64-year-old male case admitted with infected soft tissue lesion localized to left medial mid-femoral region. First appeared as an ulcerated small wound 1 year ago and gradually increased in size and complicated with purulent exudate, approximately 10 centimeters diameter. Some topical medications applied with no response, and patient was referred to plastic surgery. And this is the lesion, as you see. Biopsy from the lesion revealed plasma cells infiltrating dermis and predominantly stained with kappa, and it was reported as plasma cell neoplasia. Patient referred to our department for further evaluation of therapeutic options. Past medical history revealed uncontrolled type 2 diabetes mellitus and hypertension for 10 years. Was on oral anti-diabetic and antihypertensive therapy. 20 years ago, he wounded with a gunshot and operated twice after that event. Revascularization and internal fixation applied. Chronic osteomyelitis developed at the gunshot zone, which was the zone of current wound. Lab studies revealed no anemia, no renal failure, mild hypercalcemia, albumin of 3.7, beta-2 microglobulin was not available at that time. IgA was 246, IgG was 936, IgM was 16, kappa light chain was 264, and lambda light chain was 119. Urine protein was negative. No monoclonal gammopathy revealed in electrophoresis and immunofixation. Bone marrow aspiration showed 2% plasma cells. Bone marrow biopsies showed no plasma cell infiltration, just some reactive changes. Skeletal survey was all normal, except the femoral region. That was a malunion at the gunshot zone. And this is the MRI at the diagnosis, MRI imaging of the plasmacytoma, huge plasmacytoma. And then this is the PET-CT at the diagnosis. It's expanding from the bone to the skin. No monoclonal gammopathy, bone marrow aspiration and biopsy negative regarding plasma cell disorder, and he was diagnosed with solitary plasmacytoma. And now, what is your choice of therapy? Radiotherapy, surgical excision, systemic chemo, and radiotherapy.
Please vote
considering
now.
this lesion.
Yeah, in real life, I would have an orthopedic oncologist come by and tell us what to do. Because it's not clear. It's hard to know what the surgical issues. The area is clearly infected, and the field is radiation port is humongous, and for some reason, systemic chemo to shrink and add it doesn't sound right because it's gunshot wound history, and so a surgeon would have to be so intimately involved in this decision.
Yeah.
In hematology, in general, we don't use neoadjuvant settings in chemotherapy or radiotherapy, but this is a good idea for this patient to have a chemotherapy first and after the surgery or radiotherapy.
No, I don't think so. I just threw it out there, but I've certainly never used it prior to radiation of a plasma. Although I've never seen one like that.
That was the first for us.
With the infection, it's going to be really hard with the systemic therapy. Try and see how much the surgeon can debulk and then consider radiation following that.
Yeah. What we did, we consulted with radiation oncologists. RT not recommended because of the extreme size of the lesion. And we consulted with surgery, not recommended because of possible complications, fracture, infection, comorbidities. So we started chemotherapy with VAD again because of the governmental issues. After 2 cycles of VAD, no regression achieved considering the size of the lesion. At this point, what would you recommend?
Please vote.
Yeah, it's
Could it be a reactive plasmacytosis?
But there is osteomyelitis in the base.
Yeah.
Yeah, that's what I'm talking about. There is infection, so maybe effectively treating the infection, underlying osteomyelitis,
We
might
tried
help.
to effectively treat it with IV antibiotics, but no regression achieved.
It's not something very usual to have a plasmacytoma in a gun wound.
It's been reported, lightning strikes, it's been reported, and so, right. And so with areas of trauma, these have been reported, but with absolutely no evidence of systemic disease of any type, I'm really, really wondering if he's looking at a curative amputation.
Maybe.
Yeah, and then you're not salvaging the limb. The limb is just a mess.
Yeah.
And if radiation therapy doesn't feel the field's too large, the real question for the surgeon is, it's not repairable, you're not rotting it, maybe he's going to lose the leg. It's an enormous wound.
It seems so. What we did, we initiated bortezomib and dexamethasone after 2 cycles of VD. Significant but not full reduction achieved regarding the visual size of the lesion, about 3 or 4 centimeters. MRI ordered in order to measure the response. If a significant response approved with MRI, patient will be referred to radiation oncology and then maybe to surgery. Thank you.
What happened to case?
No, we are waiting for the MRI.
I somehow agree with Gülsen in regard to the complicated infection and the diabetic complication is also added to this, and it's been reported that hyperbaric oxygen helps in improving the
That may be
infection.
tried, yeah.
So that can be integrated into the treatment.
Yeah, that's a good point. Mr. Kaya.
Dr. Kaya.
We reported a case about 50 years ago of a man who had chronic osteomyelitis like this and the development of plasmacytoma in that area. And this patient had very, very biologically active disease, and even though he responded to initial radiation, he developed widespread disease and died in a matter of months.
Unfortunately. Myeloma. We may proceed with radiotherapy. Yeah. Thank you.
Maybe we can add something. Is there any another diagnosis option for this patient? I mean, it is possible to have another disease because it's a very it's a very problematic to diagnose solitary plasmacytomas because you don't have any other signs of this systemic disease. So I think it's better to have one more biopsy, or should perform careful immunostaining for this kind of patients because you have only one sign. And the other question is there any place for this patient to add cyclophosphamide to the therapy with bortezomib and dexamethasone?
It may or may not be. I don't know. Cyclophosphamide role.
I mean, the leg has had issues for years, and it's one thing on top of another. People, the neoadjuvant with the radiation or surgery is reasonable, but I'm with Maury. I'm fearful that it's not going to save that leg.
Yeah.
Because again, what is that going to, all that immunosuppression, what's that going to do to your chronic osteomyelitis? I mean...
perhaps nothing. Yeah.
Let's move to the last, but
This
not
is the
least
last
case.
case. And this is a case 51 years old at the time of diagnosis, and I want to emphasize that the diagnosis was put on 1997. He is a male patient admitted with fatigue, weight loss, and dyspnea on exertion, while being evaluated for normocytic anemia, diagnosed with IgG kappa multiple myeloma according to the bone marrow examination and SPEP and immunofixation. I'm sorry we have no more details because the diagnosis time is a century ago. 3 cycles of VAD with no response, 6 cycles of MP with no response applied, progressive disease, autologous stem cell transplantation tried but not applied because of mobilization failure at 1999. Thalidomide initiated, PR achieved but stopped at the 2nd year because of deep venous thrombosis. Plamidronide initiated 90 milligrams over 28 days, and he was on plamidronide from 2000 and 2002. At 2004, he was already on bisphosphonate therapy, zoledronic acid IV 4 milligrams over 28 days until 2002 to 2004. No anti-myeloma therapy, still had positive SPEP and immunofixation, IgG levels oscillating between 2,000 and 3,000 milligrams over deciliter, mild anemia and no renal dysfunction, no hypercalcemia and stable lytic lesions. Patient admitted with painful, solid and immobile swelling on right mandibular region with an approximate diameter of 4 centimeters at 2004. Detailed history achieved revealed tooth extraction 2 years earlier while on plamidronide therapy, which applied after 3 months delay of bisphosphonate. After then, recurring abscesses occurred at that region and successfully treated with antibiotics. This is the X-ray and the CT of the mandibular region. What is your diagnosis? Jaw necrosis, osteomyelitis, jaw necrosis and osteomyelitis, and others.
Bad dentist.
Can we see the picture more? After the votes, I think. So, last of us thinking that it must be jaw necrosis and osteomyelitis. Now we can get back to the radiograph and CT. There is no bone. And considering jaw necrosis due to bisphosphonates, what is your treatment choice? Withhold therapy and watch, surgical excision and reconstitution, withhold therapy and surgical excision and reconstitution. Please vote. How much pain is lots of pain.
I think the answer depends on the patient's status. I mean, if he has a pain or with no pain or the teeth problems.
He has a really tough pain. Lots of us say that withhold therapy and surgical reconstitution, excision. What we did, we referred patient to plastic surgery in order to be operated and reconstituted with the presumptive diagnosis of jaw necrosis and osteomyelitis. But the pathology revealed actinomyces colonies between bone trabecula which are expanding these areas, diffuse atypical plasma cell aggregates, ulceration at the epithelial area and granulation under epithelium. Diagnosis was plasmacytoma and actinomycosis and ulceration and granulation. After excision, IV and oral penicillin for 6 months applied in order to suppress the actinomycosis, reconstituted with metallic plugs and flaps. Bisphosphonates continued after 6 months of operation with no further complications. The progress of the patient, thalidomide with anticoagulants, bortezomib was applied for clinical relapses, mainly due to worsening anemia. He is now on 15th year of myeloma with residual disease regarding the bone marrow and immunofixation. Never achieved a better response than partial remission. He is readily on cladronate therapy and no other anti-myeloma agents, with no worsening bone disease or CRA. Thank you.
Okay. Thank you for these really interesting cases. And for the last cases, is there any question or comments? Because the problem is here a long-term use of bisphosphonates. Okay, Dr. Heidi.
Can we talk about indolent form of myeloma? So should we treat all patients with the disease? These patients lived 15 years with the disease. So response to therapy is, of course, good for us, but sometimes, like lymphomas, maybe the indolent course is also good for some patients.
Absolutely. I mean, again, we've always considered myeloma as sort of one of these chronic lymphoproliferatives, and there have been plenty of data historically to show that stable plateau is good, and this patient is an example exactly of that. And it's very exciting now that we get these high CR rates and all the rest, but it's still that myeloma is not a curative disease. We haven't really found the cure, and so, you know, we get all. So I love this case for that reason, because you're showing that somebody they're not in CR, they're in some kind of a stable plateau, and the biology of his disease is such that he could live with that. And so, again, it's a wonderful, I love that case. That's a great case.
Thank you.
It's the ultimate individualized
Yeah.
therapy. There isn't one applied therapy for all, and there's still need for clinical judgment that this patient just needs a little touch now and again, and it will likely do well actually for quite a few more years.
We hope so. Amen, yeah.
The plasmacytoma, which appeared at the site of osteonecrosis, do we have any signs of a plasmacytoma elsewhere?
No. No other signs of plasmacytoma. It's only lytic lesions regarding the bone disease.
And the duration of bisphosphonate treatment was how long?
It was about 2 years long at the time of the diagnosis of plasmacytoma.
And all through those 15 years, for how many years did he receive bisphosphonates?
He's receiving bisphosphonates until that time, chlordronates.
No, I mean if
Almost 10 years, I think. The total
around
duration
10
of
years.
bisphosphonates therapy is almost 10 years. Is it long or?
It's advised until progression you can continue on the bisphosphonate, and we are just at that point.
I think you get my point. Is the occurrence of plasmacytoma at the site of osteonecrosis is a new observation, nothing reported very often. I don't know if the Mayo faculty has experience regarding this. So in an indolent case, bisphosphonates are having anti-myeloma effect, but nevertheless we are having the complication which can lead to iatrogenic event that we don't want to see.
Yeah, that's the case.
Unexpected site for developing plasmacytoma on the ground of osteonecrosis. So any comment or question? Okay. Now we are closing the session, and now we are moving to Dr. Hayri
And Dispensary.
and Dr. Dispensary. Thank you.